Bald Truth Dental Politics Podcast News Alert. Brought to you by Dig-A-Palooza, continuing education event. More info at dentistryingeneral.com.
One thing I want to bring up, and this is again someone from the Board of Trustees of the American Dental Association. I feel like actually he's not alone. A lot of people are hurt by the procedures that were done on live patients. They had to bribe patients. They had to do all kinds of things. So their feelings are hurt. As a matter of fact, they are mad at AADEX for supposedly, based on the information they're telling me, you are not in support of the PGY-1 requirement and the OSCE.
That's a great question. Okay, so let's talk about patients for a minute. I don't use the term live patients because we're not the mortuary boards. We only treat live patients. I would prefer to treat patients with live patients in my career, but I never did. So the testing agency that I'm associated with certainly was not opposed to an alternative to patients. The problem is we did not have a simulation with the variability that a patient offers. So caries progresses, right? Decalcification to frank caries, affected dentin to infected dentin, there's stain. There's all this variable when you treat a patient. There was no simulation. We actually started working on a simulation in 2016, well before COVID. We invested millions in developing, which we now have. It's called the Compact tooth. No two teeth are the same. The caries, the amount of stained and unstained caries varies. The amount of stain without caries promulgates along the DEJ, promulgates the way caries does, but no two teeth are the same. So everybody could do an MO on number 30 and no two would be the same. So they have to do modification. So once we developed that, we went to a non-patient-based exam. And we went to the non-patient-based exam for the same reason we use advanced cardiac life support testing. There's more variability in a simulation if you can do it well than any patient can offer. And that's what we found. Actually, the Compact exam is more challenging than a patient because they chose their own patient with very tiny lesions. But I agree, the ethics of using patients during an examination is a real problem, which is why we started to develop this. It would be interesting to know that AADEX, the dental boards, not the testing agency, the dental boards, people make no money from this, don't allow patient exams anymore. So they will not even credential someone who takes a patient-based exam now. We have an administered one for several years, but believe it or not, a few schools asked for it because it was easier. We won't do it. It will only be a non-patient-based exam. So I think that argument is done. It would be like criticizing ENT for doing tonsils and adenoids when they don't do it anymore. We've gone beyond that point.
Spence, what are your thoughts about what Dr. Champagne said? It seems like to me, we made some mistakes in the past, or not mistakes, but that was all we had. And now we're improving, right?
Yeah, I'm impressed. I did not know that no two teeth are alike. As you said, Bob, we're old. We took our exams a long time ago. And I think it's impressive to hear the improvements and that the exams are challenging. In my mind, I'm thinking of what's it called, the Dentec teeth that we had, and there were no lesions. I'm satisfied that the bench test with these new teeth, what are they called again?
The teeth are called Compact teeth. They're nothing like the ivory teeth we had in the past. Yeah, there's enamel, which is exactly the same hardness as well as anatomically correct, the thickness everywhere. The dentin is exactly the hardness of dentin. It took years to do this, and the caries is variable. Like we said, every tooth is different. 1 year, every candidate had the same anterior and posterior. Performance did not improve along the year. There was no way to game the exam because no matter what you did, the next tooth was different. As far as an OSCE goes, we require an OSCE. A major component of the AADEX exam is an OSCE. It is a 5.5-hour exam taken at Prometric. It is diagnosis and treatment planning, postoperative complications. All those, you have to ask for the information you want. They are not multiple choice. There are things like extended match, fill in the blank, identification. We think it's important. You can't give an exam without an OSCE, in our opinion. But you can't give the exam without a performance exam either. Both parts are necessary. Now, as far as a PGY-1 or any advanced training, of course that's better, but it serves two different purposes. So I did my oral and maxillofacial surgery residency, but I still was certified by the American Board of Oral and Maxillofacial Surgery. I still had to take an examination at the end of that process, just like any training process. I was also a pilot. When you get your visual flight rule ratings, simple aircraft, single engine, You don't just get to train in a complex aircraft and instrument rating and just go. You take another exam if you've incorporated those skills. Training is, of course, wonderful. Mileage is very important. Experience is important, but assessments are equally important. Why do we test emergency room physicians and anesthesiologists on advanced cardiac life support? They were trained. They do it every day. They still have to maintain their test every 2 years. And when you take advanced cardiac life support, the written test isn't enough. You have to go through the performance exam in each station and actually show you can do it and make the judgment. Isn't that what we want if we're the patient?
So their pain point is that physicians go through residency and then they walk out on practice. You're telling me, no, they're being assessed as well. Meaning that if you go through the PGY-1 postgraduate, do they still have to pass this in the state of New York? Do they still have to take a test?
No, not in New York. But New York is not a PGY-1 state. That is a misnomer. New York requires you to complete an accredited postgraduate training program of whatever length it is. So if it's oral surgery, it's going to be 6 years. If it's orthodontics, it's going to be 2 or 3 years. If it's an AGD, it's going to be 2 or 3 years. A PGY-1 is a PGY-1. That's the shortest you can do, but it depends on what program you're doing, and you have to complete it. So you can't go partially through it. You can't do 2 years of a prosthodontic program and not finish it and get your license. You have to finish your postgraduate education. It's a common misnomer because other states do accept a PGY-1 in lieu of an exam. But New York's not one of those. They have.
What is your take on that as far as a state just accepting a PGY-1? This is, again, they bring this up that, hey, why not have that?
If you ask me my personal opinion, I think Delaware has had the best model. You have to do both. You have to do postgraduate residency and you have to take their licensing exam. Now, I don't agree with their state-only exam, but that's the way Delaware is. I think a PGY-1 is a good thing. I have no problem even if it's required, but I don't think it's in lieu of an exam. So when they say physicians don't do anything, no, you can't get privileges in an accredited hospital without being board certified. That's a far more rigorous exam than any dentist normally takes unless you get board certified in a field of dentistry. Not only do they have to get board certified, they have to recertify. That every 7 to 10 years, I had to recertify. I just couldn't continue to practice. And if I go to a hospital, just like every surgeon, they have to get credentialed. They just can't walk in and do things. They have to say, I want to do this. And they say, okay, let me see your experience. And that's the way, no dentist has to do that. When they graduate dental school and pass the test, they can do anything they want on a patient. There is no filter. To say that physicians have this, you can't see, every safeguard system is developed in context with everything else. So no one says the AADEX exam is good enough if you didn't have an accredited dental education, if you didn't pass the national boards as well. We base it on the candidate doing all 3 things. It's a comprehensive public protection. Same thing with medicine. They want an accredited medical education, and nobody can practice graduating medical school. That's the thing they don't tell you. There is no one who can practice out of medical school. And they're incorrect. After your first year of residency, you have to take part 3 of the United States Medical Licensing Examination Series. There's another exam. But that's not good enough because when you complete your residency, you have to be board certified within a period of time to maintain hospital privileges. So all of those things, as well as something that dentistry doesn't have at all, mandatory peer review and QA of all the cases and admissions in a hospital. So we can't compare the 2 systems. You can't cherry pick part of it because every part of the system assumes the rest of it.
Gotcha. So you're telling me that there are a lot more accountability when a physician goes through a residency that maybe the opposition is not considering. They think it's just a residency.
I think this interview should be with you. You said it much better than me and much quicker.
The OSCE, the DLOSCE is created by the ADA. The OSCE is the type of test that we're talking about, correct?
Exactly. The OSCE acronym has changed from objective structured clinical exam to objective simulated clinical exam, but whatever it is a computerized exam testing cognitive skills. Gotcha. That's what it is. So mostly you're talking about diagnosis and treatment planning and understanding postoperative complications and other things that develop postoperatively and preoperative evaluation consideration of the patient and risk assessment. For example, in the OSCE that AADEX gives, a huge part of it is perio because prognosis, PROS, and everything we do is grounded in periodontal risk assessment. All of that gets filtered. It's not a simple exam. These aren't simple questions or case-based questions. Here's a it describes the patient. You have to ask for the medical history, the models, the radiographs, et cetera. And then it'll ask you questions about treatment planning, postoperative, sequelae, things like that.
Spence, do you have anything to add here?
No, not at this point, not on this.
Okay.
For more conversations, visit dentistryingeneral.com.